you're joining in and you're getting the notification. Are you? Alright, so today's quiz is CORNEA quiz, or was CORNEA quiz. Okay, so we will start with the first question, which is about keratoplasty. Okay, which of the following has the best prognosis for keratoplasty? So you know keratoplasty is corneal transplantation. So best prognosis for keratoplasty meaning where the graft is going to survive well and where the visual improvement is also going to happen. See, both the survival of the graft is also important as well as its optical clarity. Okay, so option 1, keratoconus. Now let's assume you and I, both of us, do not know anything about this topic of keratoplasty or the prognosis after keratoplasty. Still we'll go ahead with our existing knowledge. So option A, keratoconus. Let's say I have no idea. Move on to option B, uveitis. A lot of inflammation is there, so it's actually a high risk for a post-op, again, inflammation, whether you're doing cataract surgery or you're doing keratoplasty. Post-op inflammation is going to be very high. So when you have post-op inflammation is very high, then always the success rate is going to be a little less. So let's keep that in mind. Atopic conjunctivitis. See, atopic conjunctivitis again is a very high risk for keratoplasty. Okay, because there's going to be chances of rejection, chances of vascularization and all this with atopic conjunctivitis. Glaucoma, again, poor risk because already prior raised IOP, and after keratoplasty there is, see, even normally routinely after keratoplasty there is a higher chance of glaucoma because of the graft size. Based on the graft size, whether you're taking thank you MKS. So whether it is a smaller size graft or a bigger size graft, that is a question for you. So normally when we have a bigger sized graft, okay, the donor is bigger, donor cornea size is bigger, then the chances of glaucoma is quite high, especially the angle closure glaucoma, because of the chances of peripheral anterior synechiae. And the topical steroids that we use post keratoplasty, again there's chance of glaucoma. So pre-existing glaucoma is definitely is not portending well for keratoplasty prognosis. So the answer by ruling out is keratoconus, and keratoconus by default also has got a very good prognosis after keratoplasty. Now why so? See, either I have told you two things. You either do a penetrating keratoplasty, a full thickness keratoplasty, or a DALK for keratoconus. So when would you do a DALK? You'll do a DALK as long as you don't have a deeper stromal scarring, because DALK is you leave the Descemet's membrane, right? Descemet's membrane and endothelium you leave behind. So endothelial ruptures will still be okay, because as the endothelium secretes new Descemet's membrane, that is going to be okay, right? But if you have too much of a scarring, then DALK is not a great option. You'll have to do a penetrating keratoplasty or a full thickness keratoplasty. Yes. So it is not an immune mediated disease. Keratoconus is not an immune mediated disease per se, right? So the visual prognosis is very high after keratoplasty. So the prognosis is great after keratoplasty in case of keratoconus. Okay, so that is the answer. Now, question number 2, identify the limbal stem cell marker. This is an often asked question. ABCG2, APCA4, connexin 18, aquaporin 4. ABCG2. Okay, it's a very, very often asked question. ABCG2 is the limbal stem cell marker. Now, what is this APCA4? APCA4 is an ATP binding cassette protein which is located in the outer segment of photoreceptors, and that APCA4 protein is mutated. Good evening, beta. Good evening. Nice to see you. Oh, my Yuchan, my friend. Yeah. So APCA4 is mutated in case of Stargardt's disease. Okay, so that is APCA4. Now regarding option D, aquaporin 4 you know is a biomarker for neuromyelitis optica spectrum disorder, NMOSD, or Devick's disease. So aquaporin 4 is is a water channel basically which is present in the food processes of astrocytes. So that is a primary target of neuromyelitis optica. So that is the serum levels of aquaporin 4 are elevated in NMO. Yeah. So the answer for this is straightforward. Limbal stem cell marker ABCG2. Write it down. Okay. Now endothelial plaque is seen in. Now what is this endothelial plaque? Now the moment I ask that, you have no idea. Let's look at these options. Pseudomonas keratitis, acanthamoeba keratitis, aspergillus keratitis, mycobacterial keratitis. See, endothelial plaque is a fungal ball that forms on the endothelial side, because the fungal hyphae, if you remember, they can penetrate intact Decimex membrane and go onto the endothelial side, attach itself, form a fungus ball or like a plaque. So endothelial plaque is seen in fungal keratitis. So which of the following options is a fungal keratitis? Aspergillus keratitis, right? Aspergillus is the most common cause of fungal keratitis. So that is the answer. So I have not given it straightforward as fungal corneal ulcer or fungal keratitis. The organism causing fungal keratitis is mentioned. So Aspergillus keratitis. Okay. Question number 4, the only FDA approved drug for fungal keratitis. This kind of appears very, very difficult, but it is the drug of choice, that is your natamycin eye drops. Natamycin eye drops is the only thing that is FDA approved for fungal keratitis. Okay, although you might be tempted to go for amphotericin or voriconazole eye drops or even capsifungin, which is one of the latest, but the FDA approved, the only FDA approved one is a 5% natamycin eye drops. Okay, so that was like a very kind of a googly kind of question, because the moment you see something FDA approved and you've not read only FDA approved, of course there is natamycin there. Okay, question number 5, which of the following is associated with active viral replication? So option A, disciform keratitis, option B, nummular keratitis, C, geographic ulcer, option D, mycotic keratitis. So the question asks active viral replication. So obviously option D is ruled out. Mycotic means fungus. You're talking about viral replication. So D is ruled out. So among A, B, C. See guys, I've told you option A, disciform keratitis. Somebody asked me in a previous session also. I told you it is a delayed type hypersensitivity, type 4 hypersensitivity. So it is basically a hypersensitivity reaction. There is no active viral replication involved at all. So if you listen to one of my previous discussions, you already know disciform keratitis cannot be the answer for this particular question. So it is ruled out. Now what about option B, nummular keratitis? Nummular keratitis again stromal keratitis, which is a type 3 hypersensitivity, again not a active viral replication there. So you know active viral replication means there is an epithelial involvement, that is an ulcer. Either it is a dendritic ulcer when it is really fine, thin and nice, or it has expanded to become the geographic or amoeboid ulcer. So here amongst our options, option C, geographic ulcer. So there is no dendritic ulcer in the option, there is geographic ulcer. So for geographic ulcer, again, what is the treatment of choice? Because we have active viral replication, you have to give topical antivirals, which could be acyclovir, or you can acyclovir again available as an eye ointment, or your ganciclovir available as a gel form. Okay, again like an ointment but more like a gel. Yes. Alright, so let's move to question number 6. Okay, neurotrophic keratitis is associated with damage to. Neurotrophic keratitis, I told you when there is neurotrophic T. Okay, so T means it is a T wala nerve So which is a sensory nerve, which is a T-wala nerve supplying the cornea? It is your trigeminal nerve. Yes. So trigeminal nerve. Trochlear nerve, is a purely motor nerve, nothing to do with sensation. So corneal sensation is from trigeminal nerve, the V1. Okay, V1, V2, V3. V1, your ophthalmic division of trigeminal nerve, right? So neurotrophic keratitis means something to do with your trigeminal nerve. Either it is very good, Yuchan. Yes, very, very good. So trigeminal nerve palsy per se, or because of a CP angle tumor, all that would be a neurotrophic keratitis. Yeah. Or even when you get it in cavernous sinus thrombosis, when your trigeminal nerve V1 is affected and therefore corneal sensation is affected and you got some corneal ulcer, that again would be neurotrophic keratitis. Okay, question number 7. A whorled deposit, a whorled deposit is seen on the cornea. Vision is 6/6, meaning it is not affected. Which of the following drugs is not a suspect, which is not involved? So that means what is the diagnosis here? A whorled deposit on the cornea, specifically, to be very specific, it would have been on the corneal epithelium. Yeah. So the diagnosis is vortex keratopathy or cornea verticillata. Now we know the drugs or the conditions which cause cornea verticillata. So let's mentally run through that. And because this is asking not a suspect. Amiodarone, yes, most common cause of cornea verticillata. So that is not our answer here. Netarsudil, yes. Netarsudil is that anti-glaucoma drug, rho kinase inhibitor, which can cause again cornea verticillata. So not our answer here. Hydroxychloroquine, yes, it can cause. So that is not the answer. Isoniazid. Isoniazid does not cause anything on the cornea. But what can it cause? Isoniazid. Isoniazid can cause toxic optic neuropathy. Okay, isoniazid can cause toxic optic neuropathy, but nothing on the cornea. Right? Okay, now the next question, the nerve typically causing Hutchison's sign. Now what is Hutchison's sign and where is it seen? Hutchison's sign is seen in herpes zoster ophthalmicus, HZO. What does it say? Suppose you have a herpetic lesion. You know how herpetic vesicles look like, right? So when you have herpetic lesions either at the root of the nose or at the tip of the nose, corneal involvement is very likely. Yeah, that is Hutchison's sign. And why is it? It is because of the involvement of nasociliary nerve, which is a branch of V1. Okay, ophthalmic division of trigeminal nerve. Alright. Okay. So option A, trigeminal nerve, not trigeminal nerve entirely, one specific branch of trigeminal nerve. Frontal nerve, no. Nasociliary nerve, yes, that is the answer. Anterior ethmoidal nerve, no. See, anterior ethmoidal nerve, all that you need to remember, anterior ethmoidal nerve in ophthalmology is for, we do use that to give block, anterior ethmoidal nerve block, especially when we are doing when we are doing DCR surgery, external DCR, only for that. Because when you make a flap on the nasal mucosa, you need a proper anesthesia, although you'll be, stuffing the nose with the packs and all that, but still, so that's the only time when you need an anterior ethmoidal nerve block. Other than that, nothing in ophthalmology. Okay, now question number 9, layers inflamed in interstitial keratitis. So the answer is, although it is in bracket, that S, layers, the definition of interstitial keratitis is